Public Health at the University of Toronto. She's currently affiliated with the Leong Centre at Sick Kids, the Department of Health and Society at the University of Toronto Scarborough, as well as ICES. Her presentation today will focus on the latest research on prenatal opioid exposure in Ontario, its impact on child health, as well as opportunities for promoting healthy child development in Canada. I'm now going to pass it over to Dr. Camden.
Thanks very much, Priscilla. Just going to share my screen. Okay. Sorry, I just need to move a few things. Okay. So thank you so much for having me today. My presentation is going to focus on prenatal opioid exposure and supporting healthy beginnings. So I don't have any potential conflicts of interest to disclose. And over the next 45 minutes or so, my objectives are to discuss the use of administrative data to describe the epidemiology of prenatal opioid exposure, to talk about the impact of prenatal opioid exposure on child health and development, and to share some preliminary findings from a rapid review that we're working on of strategies to optimize developmental health in children with prenatal opioid exposure. And then lastly, I'd like to wrap up just discussing some opportunities to strengthen Canada's response to support children with prenatal opioid exposure. So I thought I'd start with a background, the broad background, just with a few statistics about the opioid crisis in Canada for context. So from January 2016 to March 2023, there have been just over 38,000 deaths and just under 38,000 hospitalizations related to opioid toxicity in Canada. Mortality rates continue to increase over time, and they now average 21 deaths per day from opioid toxicity in Canada and around 8 deaths per day in Ontario. As you can see from the graph on the right, mortality rates have really been exacerbated by the COVID-19 pandemic. And I think it's important to keep in mind that these statistics really do represent the tip of the iceberg. So there are numerous opioid-related health events that occur without contact with the healthcare system that go uncounted. So my program of research focuses on a different segment of the population that's also been adversely affected by the opioid crisis, which is pregnant people and children. So when I talk about opioid use in pregnancy, I'm referring to opioids used therapeutically for pain management or for treatment of opioid use disorder, in addition to non-medical use of opioids from the street supply. So that would include heroin or fentanyl. And today I'm going to focus on prenatal opioid exposure in relation to child health and development, and I'll be sharing some of the research that I've conducted with Dr. Astrid Gutman and some other sick kid scientists using ICS data. So just historically in Ontario, we've seen dramatic increases in opioid use in pregnancy as evidenced through two different indicators. So we've seen a 16-fold increase in the number of infants born to women with opioid use disorder from 2002 to 2014 in Ontario. And we've also seen similar increases in the rate of neonatal abstinence syndrome. However, some of the more historical data has focused more on recipients of the Ontario Drug Benefit Program, or has been limited to neonatal abstinence syndrome, or has been self-reported. So there's been some limitations. Nevertheless, prenatal opioid exposure is a really important public health issue. We know that it's associated with a range of adverse health outcomes among pregnant people, infants, and children. So specifically in pregnant people, we tend to see an increased risk of communicable disease, so STIs, hepatitis, endocarditis. We see increased risk of sepsis, opioid toxicity, and mortality. And then in infants, there's a higher risk of neonatal abstinence syndrome, of preterm birth, or being born with low birth weight, small for gestational age. We see smaller head circumferences, and increased risk of congenital anomalies, longer birth hospitalizations, and mortality. And then in children, we see an increased risk of developmental outcomes, visual deficiencies, and we see higher rates of acute healthcare utilization, but lower rates of well child care. So the focus of today will be on children and specifically development. So next I'm just going to discuss how we use ICES data. So in Ontario, really fortunate to have access to one of the world's largest health administrative data holdings. Ontario's health data are held at ICES, so it's a not-for-profit research institute funded by the Ontario Ministry of Health. So ICES uses encrypted health card numbers to link information from various databases, in addition to linking the maternal and newborn hospital records. And being able to identify this linked dyad is a really critical piece in understanding the effects of prenatal opioid exposure and also the context of opioid use. So we use several of these different databases to identify maternal and child characteristics, as well as opioid use. So to measure opioid use in pregnancy using ICS data, we use 5 different databases. So the first is prescription opioids. So we are able to identify all prescription opioid records in Ontario through the narcotic monitoring system. So this is a really important database in our research. And through this database, we can differentiate between opioids for pain management and opioids for treatment of opioid use disorder. We also look at maternal opioid-related hospital records. So this could include visits, ED visits or hospitalizations for opioid use disorder, toxicity, or adverse events. And then we look at newborn hospital records for neonatal abstinence syndrome or exposure to maternal drugs of addiction. And then lastly, we're able to look at outpatient visits for opioid agonist therapy. And as you can imagine, it's pretty difficult in health administrative data to identify opioid use from the street supply. But because we have these different databases, we're able to kind of triangulate and come up with a measure. So when we see records that have a hospital event that's related to opioids, but we can't identify a prescription opioid record or outpatient physician visits, we assume that these are an exposure from opioids from the street supply. So using ICS databases, we're actually able to identify infants with neonatal abstinence syndrome back to 1988. We can start to identify prescription opioid records for ODB beneficiaries back to 1990. So this is kind of the start of when you can differentiate between types of opioid exposures. And then we have outpatient physician visits for opioid agonist therapy starting in September 2011, and prescription opioid records for the whole population starting in July 2012. So we can really follow mothers and children over time, currently until 2023, to measure long-term health and developmental outcomes. So we use these methods, this is work from my PhD, to estimate prevalence of prenatal opioid use in the whole population in Ontario. So over the study period from 2014 to 2019, we estimated that around 5% of births had some type of prenatal opioid exposure. And as you can see from the dark blue line here, prevalence ranged from around 6.1% in 2014 down to 4.5% in 2019. And when we look specifically at the type of exposure, you can see from this dark yellow line that represents opioid analgesics that they're the most commonly used opioid in pregnancy, and we're really decreasing over our study period. We hypothesize that this decrease is likely due to changes in clinical practice guidelines in 2011 and 2017 to promote safer opioid prescribing. And then this is the overall, or this trend here is influencing the overall declining trend in prenatal opioid exposure. But when we look at other measures like maternal hospital-related care or neonatal abstinence syndrome, we tend to see these staying stable over the study period. And it's really these types of exposures where we tend to see stronger associations with adverse health outcomes. So as we go on to discuss child health and development, it's really important that we keep in mind the context of opioid use in pregnancy. So we know that prenatal opioid use tends to occur in pretty complex contexts characterized by high rates of medical comorbidity, social risk factors, and also stigma, discrimination, and numerous barriers to care. So we know that maternal health is a critical determinant of long-term child health. and that all of these factors can really compound the risk of adverse health outcomes. However, we found that a lot of studies really were classifying opioid exposure very broadly, and there wasn't a lot of characterization around the diverse circumstances around the type of opioid use. So we addressed this knowledge gap in my PhD using several characteristics from ICS data, where we identified clinically distinguishable groups of people who used opioids in pregnancy in an effort to attempt to identify people who may benefit from targeted intervention strategies. So we used some person-centered methods that included 20 different socio-demographic and clinical characteristics, including the type of opioid used in pregnancy. And our goal here was to identify different clusters of people who used opioids. So we had around 31,000 pregnant people with opioid use in pregnancy. And we identified 5 different groups that I'll just briefly discuss. So the first and the largest group we identified represented 44% of people who used opioids in pregnancy. This group was really characterized by short-term pain management. They had a very low risk profile, so really resembled what we see in the general population in Ontario for pregnant people. The second group we identified represented 23% of people. This group was characterized more by long-term opioid analgesic use. So we saw high rates of comorbidity and pain-related conditions and more chronic use of opioid analgesics. The third group also used opioid analgesics, but this group was quite young. They were predominantly 12 to 24, and we also saw high rates of hospital care related to pain and mental illness. The fourth group was characterized by receiving medication for opioid use disorder or also using opioids from the street supply. This group were most likely to live in rural areas and low income areas. They also have very high parity. And then lastly, the last group we identified was a small group, but it was characterized by different types of opioid use. But what really brought this group together was having high medical and social needs. So we saw very high rates of social vulnerability, hospital care related to mental illness, social vulnerability, polysubstance use, medical comorbidities, and high percent of people living in low-income neighborhoods. So these factors are really important determinants of health. They're also quite complicated when you want to examine long-term health outcomes. So while the focus of this presentation is on child health and development, I think these factors are really important to consider because they demonstrate why integrative care and family-centered approaches are so important. So opioids cross the placenta and they can have adverse effects on fetal health and neurodevelopment, which can result in lower brain volumes and smaller head circumference. And these factors can also be compounded by a range of other factors that influence development among families affected by opioid use. So in this diagram, you can see that there's a number of different maternal factors. So, the type of drugs that are taken, the amount, timing, and frequency in pregnancy, whether there's polysubstance use, nutrition, co-occurring medical factors, additional medications, a lack of prenatal care or medical care. Frequently, we see histories of violence and trauma. In terms of the environment, supportive care such as caregiver responses are quite important, and then child factors as well. So genetics, epigenetics, whether neonatal abstinence syndrome was present, and different comorbidities and medications. Okay, so we were really interested in understanding more about developmental health outcomes associated with prenatal opioid exposure. And we had noticed that there was really this quickly growing body of evidence on prenatal opioid exposure and a range of developmental health outcomes in children. So we summarized this research in a paper that was published in Healthcare Quarterly. We also reviewed practice guidelines, and we emphasized the need in this paper to strengthen current Canadian recommendations for developmental and visual screening to support child development among children with prenatal opioid exposure. So in this paper, we conducted a narrative review where we wanted to identify any published reviews or meta-analyses on prenatal opioid exposure in child development, and also any recent primary studies that reference these reviews in order to capture more recent literature. So what we found were 7 meta-analyses since 2015, and they consistently demonstrated worse outcomes for children with compared to children without prenatal opioid exposure. And we saw that there was a range of developmental domains that were affected, including cognition, language, motor function, socio-emotional skills, and visual deficiencies. And these disparities were seen across age groups as well. So we noted it in 0 to 24 months, 3 to 6, and then 7 to 18 years old. In terms of the primary articles, we identified 20 recent primary articles since 2017. In the human studies, again, it was noted that there were multiple developmental impairments due to prenatal opioid exposure and likely a combination of socio-environmental risk factors, including speech disorder, developmental delay, behavioral emotional disorders, and strabismus. And importantly, what these studies noted is that in children with prenatal opioid exposure, both those with and without neonatal abstinence syndrome were really at an increased risk for developmental difficulties across a range of domains. In the animal studies that we identified, there was a direct link between prenatal opioid exposure and impaired neurodevelopmental and behavioral outcomes. So these were outcomes such as impaired memory, anxiety symptoms, and increased likelihood of addiction. I should mention as well that there are a number of challenges investigating long-term outcomes. So a lot of these studies had important methodological limitations such as small sample size, poor control over confounding variables. There were differences in study characteristics such as the type of opioid, the age of the children at assessment. So it does make it challenging to draw definitive conclusions about the direct effects of opioid exposure. Some of the key takeaways from this work is that all children really should be receiving enhanced developmental surveillance, including visual and neurodevelopmental assessment, and that strategies to support families impacted by opioid use, including integrated treatment models and parenting programs, have the potential to mitigate some of the long-term developmental consequences of prenatal opioid exposure. So following this paper, we were curious to see, to learn more about developmental health, specifically in Ontario. Unfortunately, at the time, we weren't able to access linked early development instrument data, but we were able to investigate well child care and developmental screening. So this is also some work from my PhD. So in this study, our aim was to evaluate patterns of routine preventive care, including the recommended number of well child visits in the first 2 years of life, and also the universal developmental screening at the 18-month enhanced well child visit among children with prenatal opioid exposure. So we conducted a cohort study, and we included just over 22,000 children with prenatal opioid exposure that were born between January 2014 and 2018, and we followed them until age 2. And we also identified important social determinants of health that were associated with receiving these outcomes. So this graph represents the percent of children who received either the recommended 5 or more well child care visits by age 2, so those are in the navy bars, and then developmental screening at the 18-month enhanced well child visit, represented by the lighter blue bars. And it's stratified by the type of prenatal exposure. So you can see that there's disparities by type of prenatal opioid exposure, with children who are exposed to, or children who are born to mothers who were using medication for opioid use disorder or opioids from the street supply as being the least likely to receive the recommended well child care and developmental screenings. And these would be the children who are at highest risk of developmental health concerns. We also did a sensitivity analysis where we looked at any type of developmental screening in Ontario, and the results were quite similar. And Dr. Gutman conducted a study a few years ago looking at attendance of the 18-month well-child visit among all children in Ontario, and estimated that around 61% of children received this visit. So as you can see, children with certain types of prenatal opioid exposure are much likely to be receiving this care. So in our analysis of factors associated with receiving the study outcomes, we identified having a primary care provider, both for the mother and the child, as a really important variable that was associated with an increased likelihood of receiving the study outcomes. Whereas type of prenatal opioid exposure, certain demographics, such as area level deprivation, maternal age at first birth, social risk, and maternal mental health were associated with a decreased likelihood of receiving these outcomes. I should also mention that for mothers who were using medication for opioid use disorder or opioids from the street supply, around a third of them had a regular primary care provider. And then if you look at mothers who were using opioid analgesics on a short-term basis, it's around 60%. So there's quite a difference in having a regular care provider. So from this study, our key takeaways were that we identified important disparities in well-child care and developmental screening. We think this likely reflects a combination of stigma, discrimination, and different barriers to care. And these findings really demonstrate the need to improve attendance to ensure optimal child outcomes, which could be done through strategies to improve access to primary care and also strengthening practice guidelines. So now in my postdoc work, we are interested in learning how other jurisdictions have been supporting developmental health in this population. So we had a few questions after some of the work we had done, wondering like what would a minimum standard of care look like for children with prenatal opioid exposure, what types of supports and services are needed. And we were curious to learn what we could learn from the available literature on existing programs or models of care that would really be useful for us in Canada to be able to strengthen evidence-based practice and policy guidelines. So our research objectives for this study were to identify and describe different strategies. So this could include different models of care, practice guidelines, policies, or programs focused directly on healthy development for children with prenatal opioid exposure, and also for subgroups of interest. So for Indigenous people and also for children involved with child welfare. And then where available, we wanted to be able to describe the effectiveness of different strategies to understand which programs work for people. And so we conducted a rapid review of key strategies to optimize developmental health in children with prenatal opioid exposure. And this study really involves 4 different components. So the peer-reviewed literature, the gray literature, we identified clinical practice guidelines, and we were also interested in legal settlements as well. So I just want to mention this work is in progress. So these are preliminary findings. So we developed a search strategy for the peer-reviewed literature with a librarian at CHES. And we used search terms to identify any program evaluation, clinical practice guideline, program, or model of care that was directly related to optimizing child development for children with prenatal opioid exposure or prenatal substance exposure. We searched Medline, Embase, and PsycInfo from inception to April 2023. And we screened just over 1,000 studies and included 21 in our final review. And then we modified this search strategy for the gray literature, and we repeated the search and reviewed around 82 different resources. So we're still synthesizing the results from the study, but I would like to share a few key strategies we've identified so far. We've categorized them into entitlement programs, community-based programs, clinical programs, and then other. So we've identified several entitlement programs in the US that children with prenatal opioid exposure are eligible for. The first one is the Head Start program. So it's a program that's funded by the federal government, and it supports children's growth from birth to age 5. And the services are really centered around early learning and development, health, and family well-being. And these programs deliver child development services that address different approaches to learning, social and emotional development, language and literacy, cognition, and physical development. There's also the early intervention program. So these services are available in all areas of the U.S. as part of Part C of the Individuals with Disabilities Education Act. So services and supports are available to babies and young children with developmental delays and disabilities and their families. And children with prenatal opioid exposure qualify for this program because they're at a higher risk of developmental concerns. Home visiting programs are really important, similar to our Healthy Babies, Healthy Children. In the States, they have one called the Maternal, Infant, and Early Childhood Home Visiting Program that really covers clinical care, community-based supports, parenting practices, and it also has a telehealth component as well for people in rural communities. And then the Child Abuse Prevention and Treatment Act also includes something called the Plan of Safe Care. So the Plan of Safe Care is designed to improve the safety and well-being of infants who've been affected by prenatal substance exposure. And it's also designed to improve recovery outcomes for their caregiver. So it really is a family-centered approach. It's determined by each state. And they're individualized. Typically, they're developed with various healthcare professionals in collaboration with child welfare as well. So these programs really focus on developmental screening and assessment. They link people to different intervention services. They provide medical services, and there's a home visiting component as well. In terms of some of the community-based programs, Breaking the Cycle in Toronto is a great example of this. So Mothercraft delivers the Breaking the Cycle program, which is an early identification and prevention program to reduce the risk and enhance the development for substance-exposed children. This program ranges from the prenatal period to 6 years of age. And it's also another family-centered approach. It's kind of like a one-stop shop for addiction counseling, health and medical services, parenting support, developmental screening and assessment, interventions, and childcare. And then in terms of clinical programs, we identified a number of outpatient follow-up clinics, so pretty similar to neonatal follow-up clinics in Ontario. But there are specific clinics for infants with prenatal substance exposure. So one example, the Children's Hospital of Philadelphia offers a Resilience After Infant Substance Exposure program, which is a follow-up clinic. It begins at 6 to 8 weeks and it goes all the way until 5 years. So they really follow children over time and they provide assessments along a trajectory of development to be able to proactively intervene with support if necessary. And then there's this other category as well. So this includes different tools. So a few things we've noticed, there's been a best practice discharge bundle or discharge checklists. And this is an example of one. So this one's published by the American Academy of Pediatrics, and it's for infants with opioid exposure. So you can see that there's all these tasks that happen at the discharge from the birth hospitalization. And I think one of the ones that's really important, there's this pediatrician or primary care provider follow-up visit scheduled within 48 hours of discharge, and then referrals to a number of the different entitlement programs that I discussed on the previous slide. Another interesting finding is in BC. So BC has recently developed a provincial blueprint for a perinatal substance use continuum of care. So this document has 38 different recommendations that describe evidence and leading practice, and it includes Indigenous approaches to advance the perinatal substance use continuum of services and supports. So child development is mentioned in this document, and you can see there's just this continuum from prenatal care, labor and delivery, postpartum, and then different transitions. So some of the common elements in the different strategies that we identified are really having this important family-oriented integrated care. So at the beginning of the presentation, I shared a number of characteristics that are common in families where parents use opioid use. And it's really important in integrated care that a number of these different social determinants of health are being addressed. We can see developmental and vision screening. Parent education is really important in terms of development. So being able to teach parents what typical developmental milestones are. So parents and healthcare providers are looking out for different developmental milestones. And then home visits also play a large role in a lot of the strategies that we've seen. So we used a Google search to identify clinical practice guidelines for children with prenatal opioid exposure or neonatal abstinence syndrome. And we looked specifically for guidelines that mentioned follow-up or assessment for child development. We included published and unpublished practice guidelines, national, state, different organizational levels. And where applicable, we reviewed the most recent version. So far we've identified 10 different clinical practice guidelines for children with prenatal opioid exposure or NAS, 3 in Canada, 5 in the US, 1 specific to Indigenous people. There's 1 in the UK and 1 in Australia. So I thought I would share some of the language that are in these practice guidelines just to give you a sense of, I guess, some of the areas we can build on. So the Canadian Pediatric Society published guidelines for infants with opioid exposure in 2019. And these guidelines say that on discharge, there should be a referral to a primary care provider who's familiar with infant neurodevelopmental assessment, and that there should be consideration for community referrals for infant development programs. PCMCH has also published practice guidelines for children with neonatal abstinence syndrome. And again, we see similar language where children should be offered ongoing developmental assessment, may benefit from neonatal follow-up clinics and developmental assessments, and that public health nurse home visits are important for identifying developmental concerns. BC recently published clinical practice guidelines this year. Their recommendations include providing postpartum support, including infant development support in primary care settings. In the US, their clinical practice guidelines are a little bit more detailed. So the American Academy of Pediatrics has to offer developmental screening in addition to referral to early intervention services, developmental screening, and a NICU developmental assessment. And then strong consideration for some of the programs that we discussed. So the Early Head Start program, plans of safe care, and the discharge checklist. And then there's a collaboration between the American Pediatrics and the Indian Health Service. And this one actually has more specific instructions. So there's developmental screening at every well child care visit, concerns to be addressed with standardized screening, and then developmental screening at 9, 18, 24, or 30-month well child care visits. And then early referral to the early intervention services. In Australia, they also mentioned developing a plan of supportive care and recommended follow-up for developmental screening and testing. Australia is unique that they also mention vision concerns. So they have developmental and visual follow-up for at least 12 to 24 months, and also recommend intervention programs for speech and language and occupational issues. So the last component was to look at different opioid settlements between government and pharmaceutical companies. So Lily, who's a medical student who's working on this, found this opioid settlement tracker website where we can see what the settlements look like. And there's been a few states that have actually allocated their funds. So in the US, they have a document that specifically outlines how funds are allowed to be used. And in it is NAS is included, so expanding services and care for children with NAS and their families. is mentioned. However, no mention of just prenatal opioid exposure. But you can see the amount of money in the settlement in the green bars, and then the pink line represents the percent of funds that have been allocated to NAS. So you can see it's like less than 1% to around 12% of funds have been allocated to the care of children with NAS. So in Canada, there's been a $150 million settlement against Purdue Pharma, but it doesn't look like any of the funds have been allocated yet. So a few preliminary takeaways are that really there's been few evaluations that have happened in the literature, and this definitely makes it challenging to develop evidence-based recommendations. We've seen a lack of programs focused on specific subgroups, so Indigenous communities and children under the care of Child Protective Services. And then, as you could see from the clinical practice guidelines, there's really a lack of specific guidance on developmental follow-up in terms of the type of assessment and also the timing of assessment. So there's a number of different opportunities that we have. One of the ones that Dr. Gutman and I are quite interested in is engaging with the Canadian Pediatric Society and using this research we're conducting now to be able to come up with some recommendations to strengthen clinical practice guidelines in Canada and to actually provide a more unified federal approach. Developing a continuum of care is really important. There could be opportunities to work with community partners to try to advocate for the allocation of the Canadian settlement funds. There's also opportunities to develop more entitlement programs, so that could be piggybacking on existing programs or new programs. And then also in terms of toolkits. So we've seen other jurisdictions have these discharge bundles or checklists, and creating evidence-based resources both for parents and for caregivers and practitioners. Physician incentives, I know the evidence is a little bit mixed on this, but we've seen how important it is that people who use opioids have primary care providers. So this could be one way to encourage that. Ensuring that the treatment and care is integrated and family-centered. And then, of course, there's research opportunities in terms of the long-term health outcomes, and also being able to actually evaluate interventions, I think will be a really important piece in being able to develop evidence-based recommendations. So just in summary, I hope we've shown you that administrative data is a rich source of information to identify prenatal opioid exposure and to evaluate long-term child health and developmental outcomes. Around 5% of births in Ontario have prenatal opioid exposure, and we have identified disparities in well child care and developmental screening. And then there's this growing body of evidence suggesting that children are at a higher risk of developmental health concerns. And we're hoping with our latest project that we'll be able to identify some key strategies to strengthen Canada's approach to optimize developmental health in children with prenatal opioid exposure. And then just quickly in terms of next steps, Dr. Gutman and I are continuing to work on this research to support children with prenatal opioid exposure. We also have other work going on to evaluate the impact of the pandemic on opioid use in pregnancy, in addition to pregnancy-associated opioid toxicity and opioid-related mortality. And then I also split my time in my postdoc with Dr. Hilary Brown. So we have work underway where we're looking at opioid use in pregnancy among people with disabilities and among women of reproductive age. And this research is really exciting. We're taking an inclusive approach. So we have an advisory group of people with lived experience, pregnancy, and medication use and disability. And I just wanted to acknowledge all of the people who have contributed to the work that I've shared today, and also my funding from CHR, CHES in my PhD, and ICES. So I'm happy to answer questions. I'm also, I don't know, maybe unconventional, but I'm also really curious to hear if anybody's had success in influencing practice guidelines, or I guess have any tips or strategies in terms of policy development to support child health.
Perfect. Thank you so much, Dr. Camden, for such a great presentation. For me, it was really enlightening to hear more about your work. At this time, I'd like to ask if anyone has any questions to please raise their virtual hand. You are certainly Also welcome to leave your questions in the chat for our speaker, and I'll make sure to bring them to her attention. Perfect. Freddie, would you like to unmute your mic?
Yeah, hi there. Can you hear me there okay?
Yes.
Hi there, my name's Freddie. I'm a pediatric ophthalmology fellow here at CHES. I'm from Scotland, UK, where we've been seeing issues with opioid-related exposure in the pediatric ophthalmology clinics for quite some years. And we're looking at specifically at children with nystagmus here and finding high rates of those in our clinics who have had pregnancy exposure to opioids. But often we're finding that the issue is that that hasn't been known about for quite some time through the patient's journey for one of many reasons, and that people didn't maybe think to ask initially, but also potentially because of a lack of there being an obvious way to identify those children from the record. Is there any way that you have found that's a sensitive way to be able to identify these children in their, say, in their EPIC record or in other forms of electronic patient record?
Esther, do you want to go? I can't really comment on the clinical piece. I do feel like a big part of that is also stigma. So I feel like there's so much fear against like the involvement of child welfare and discrimination that I think obviously people are less likely to disclose that. In terms of the actual health record, I don't know if you have any thoughts on that, Esther.
No, I mean, I don't, not Freddie, not from Epic. I would say that, it's been interesting to be working in this field for the last few years because it is a fairly new field. And I think that it's, given how prevalent it is, we need to be sort of, thinking about this as a more common phenomenon, probably screening for it more. We've done actually quite a bit of work with First Nations communities now and qualitative work. And as Andy says, like dealing with the stigma is a huge part of it. And I think, at least now and in those communities, the majority of the use is the treatment for opioid use disorder. And I think, asking, what medications mothers are on, during pregnancy, is a pretty standard question. So, yeah, I don't know. I don't have a good answer for that yet. I mean, a big part of the work that we're trying to do is around the stigma, right? Is just, getting it out there. But I think also people are pretty unaware of how widespread and how prevalent, this is. So that may be why people aren't asking, other clinicians aren't asking. So you're having to do it. And the eye thing is interesting. Andy, did you mention, like in the Australian guidelines, they are recommending an eye, an eye exam, and we know already. I mean, I'm sure you're aware that most kids are not. I mean, the rates of just eye screening in the province are pretty pathetic, as it is. So, but to at least make sure these kids are getting it would be important, and maybe the timing of it too.
Absolutely, and thanks very much for your talk. That was really great. Cheers.
Thank you so much, Freddie. Go ahead, Astrid.
Sorry, Freddie, are you working with Helen by any chance? Is Helen on the call?
It was Helen that put me kind of onto this meeting.
Okay. Oh, perfect. Because maybe we can circle back to you while we're, as we start to get that report together about some recommendations, just around the ophthalmologic piece of it, would be great.
Yeah, that would be excellent.
Okay.
Perfect. Thank you so much for your question, Freddie. Are there any other additional questions from those on today's call? Andy, is that you sharing your screen by chance?
That's not me. I wouldn't purposely make more of me on my screen.
Not sure who is screen sharing at the moment.
Is it Antonia? I'm not.
No. Okay. Are there others that are on the call with questions for Dr. Camden? We also have Dr. Astrid Goodman on the call for questions as well.
I'm not screen sharing, by the way. I have no idea why it
Okay.
looks this way. Sorry.
Nope, that's fine. I just wanted to check in. A question that I have for you, Dr. Camden, is related to your next steps around recommendations. I'm curious how you're working through your engagement plan, as that will be incredibly important in moving this work forward. What sort of processes, activities, or strategies have you seen thus far that you might be interested in adopting and adapting for the purposes of your work?
So I think engagement with community members is really important. So that eventually will be one piece of people with lived experience. And then so far, I think our immediate plans are to use some existing connections and relationships that Astrid has. So we'll connect with Canadian Pediatric Society. We also have some plans to talk with some policy experts as well on how we can approach some of the, I think, more of like the advocacy work around the settlements. And maybe we'll be in touch with you to develop a more concrete plan around it.
Absolutely, I certainly would be interested in that piece. There we go. We're not screen sharing anymore.
Okay.
Are there any additional questions that we have on the call for Dr. Camden in regards to her work? Please feel free again to raise your virtual hand or to pose your question in the chat. Okay. Oh, I have a question. Yep, perfect. Amen. If you could just unmute yourself.
Hi, thanks for this. It was really a great presentation. I wondered if you could speak a little bit more to what work you've done around community engagement, because I think this is such important work to do collaboratively with communities.
Mm-hmm.
So I wondered if you could just comment on that.
For sure, I agree. It's really important. Unfortunately, during my PhD, I didn't do any engagement at all. I think it was I'm not sure the right term to use. Moving forward in my postdoc, I have plans, like my work with Dr. Hillary Brown involves an advisory committee. I've been working with Priscilla to put together a plan to include people with lived experience. So it's definitely something that we'll be doing moving forward. But unfortunately, during my PhD, I didn't do any community engagement.
Thanks for that. I think it'll be really interesting to see what emerges as you do more collaboration with people with lived experience,
Mm-hmm.
and then with communities as a whole. Because I think, Astrid, you're quite right that the stigma piece is huge, and I wonder what can be learned around addressing stigma in collaboration.
Yeah, Niman, we did do, but Andi wasn't directly involved with the work. So we worked with 13 First Nations communities who, they came because they wanted to address the problem. And a big part of what we did was qualitative. We just put the report out actually 2 weeks ago. I'm happy to send you. And honestly, it's, when you know this because you work with administrative data as well, I feel like the administrative data piece was, helpful to communities. They wanted to know their numbers. They knew it was a problem. They just didn't know the extent. But the piece of the report that was, all the work from focus groups with people with lived experience, providers, all of that was much, much richer, and really spoke to all of that, and actually spoke to kind of the solution space as well. Where do we need to go next? So completely agree that it's incredibly important in this work. So really, and again, it's even like our fixation with like getting a clinical practice guideline. I feel like it's just like one little piece where I know how to work the system for a problem that is very, very complex, and the context on, in First Nations is different than people living in cities or, different communities that have been affected by the opioid, like all of that context and where how you're going to move forward is also quite specific. And it will not just be around one little piece of getting a CPG in, but at least we can start there. And for Jordan's principles, it's not unimportant, right? So for trying to get funding for at least a modicum of standard of care, knowing that the medical system is not going to be the full fix for anything. So, yeah.
Thank you so much for your question, Imana, and Astrid, of course, for plugging the POE aggregate report. I think there's such richness to that report, and certainly a resource to be shared widely. I see that we have another question. Teresa, would you like to unmute yourself?
Yes, I'm unmuted, I think. Can you hear me?
Yes, we can hear you.
Yeah, sorry, my camera is not working. Andi and Astrid, great work as always. Really enjoy your talk. My question is related to data and cohort. Andi, in your PhD, you linked the data and used, a latent class to be able to classify or identify groups of mothers. I wonder whether you have given it further thought about creating not just the mother and the child, but the entire family tree. I know that it's hard to find the father, but you definitely could find the biological mother and all the children born to the mother, and whether there's only one child with the problem, or all the offspring of the problem, or just one and the rest are good. So you'll be able to find what the magnitude of the problem may be, and what may work, what may not work. Why would some mother subsequent kids have no problems, and why mother with all the kids born with the problem? So I wonder whether you have thought about doing a more massive linkage, more massive outcome, and do a big longitudinal latent class as opposed to a cross-sectional latent class kind of approach, like a mega machine learning type of approach. Thoughts?
Yeah, I mean, a mega machine learning would be really interesting. At one point in my PhD, we had talked about doing a sibling analysis. And I think that a little bit different from what you're saying, but I think that also would be really interesting, just to be able to control some of the more family and some of the genetic factors, and looking at long-term health outcomes. I think, if tax filer was linked, we would be able to create a household. So I've definitely thought about that a lot. But we don't have access to that. So that makes creating, the family unit a little bit more challenging. But no, it would be really interesting to look at families in terms of siblings moving forward. I'll add it to my long list. Thank you.
Thank you so much for the question, Teresa. I'm looking at the time now. We have a couple of minutes left. If there are any questions lingering from those on the call, again, please feel free to enter them into your chat. All right. If you do have any additional questions, I encourage you to reach out directly to Dr. Camden. Thank you so much for joining us today. And of course, Dr. Camden, for discussing your work on prenatal opioid exposure. This brings us to the end of today's session. I want to wish everyone a great rest of the day, and we certainly look forward to seeing you at our next session. Bye now.
Thanks for having me. Bye.